Thank you very much. So I'm going to start by saying that his presentation and their model is my dream as the adult provider. I wish it was the reality of everywhere. I don't think it is, and that's one of my interests as a med peds. Actually, the fellow he was mentioning was my co-resident, so she went to the ped side and I went to the adult side with the same interest in getting the patients transitioned. Where you are, the support and so forth makes a big difference. So my take today is how to help you guys as you navigate and sort of hitting on some of the key concepts, but from the patient perspective and what I experience and what I think is a much less set up model and probably more real reality to the average patient and family going through it. So we'll focus first a little bit on the differences between adult and pediatric care, where the timing and the keys to successful transition I think exist even without a great setup. And then more specifically with pulmonary care, some of the differences. So just from a thought process, as a pediatrician, what I noticed was that pediatric care is really family-oriented, relies on parental involvement in decision-making. Until 18, the patient doesn't make their own decisions, can't sign consent, etc. So there is no choice but to involve the parent or guardian. Then you flip to the adult side where it's like all of a sudden you turn 18 and now the patient is the one that has to make the calls. The front desk is saying, oh, I can't talk to you, you're not the patient, right? Unless you have signed paperwork. You have the issues that come from the difference in, oh, how are you? And the pediatric sort of friendly side of things to more of the adult business-like model. And it really, I think for a lot of people who have spent their time in a pediatric setting with chronic disease or symptoms, whether it's pulmonary or ranges a spectrum, you transition to the adult side and sort of find a cold world that is just more an adult model, not meant to be cold, but just more business-like. From the start of the phone calls, the front desk, the insurance system, etc., not necessarily the individual provider, but the way the whole process works. And so on the adult side, it's much more like autonomous to the patient, which leaves patients who have either physical, intellectual disabilities, nonverbal, in a challenging place that the adult system doesn't quite know what to do with. And I said as a med peds resident, I don't think adult providers have a problem with geriatric patients when they have dementia or they've had a stroke or something. That's no big deal. Oh, your loved one can't call, we'll talk to you. But somehow the 18, 19, 20-year-old transitioning, there's a big issue in that space and a lack of, I don't think it's knowledge, I think it's a lack of experience and awareness and so forth. And so expecting patients that are 18 and 19 who have been in this care world to be able to transition without the family is really a challenge. There needs to be a role for the family or caregivers to continue. We also lose a lot of interdisciplinary resources, and the key success in their program, I think, is funding from wherever or hospital support that provides the social workers and the clinical navigators and so forth. And that doesn't exist most places. In the pediatric side of things, there is a lot of support. That seems to go away in the adult side. So we've talked about different models. I don't think there is a true way in any institution. Everyone seems to be a little different, still trying to figure it out despite being studied and so forth. But it is still widely accepted that this transition needs to be timed out right and needs to be specific to each individual person. I think the pediatrician side of things is much better at determining, yes, is the right time and not pushing people out too soon, but maybe not as good at letting go. On the adult side, I think the acceptance of the patient is variable depending on physician's comfort. We aim for 18 to 21. I can tell you I get people rarely at 18 on the adult side and more often like 25. And I think it depends on the system. There are some systems where you hit a birthday at this date and they will not let you in the pediatric hospital anymore. The providers aren't allowed to see you, and others that are more lax in terms of those age cutoffs. So the American Academy of Pediatrics, American Academy of Family Physicians, Internal Medicine, sort of all got together and came up with sort of the keys to success. And I think when I think of helping families go through it, my thought process, I thought we'd hit on the 6 keys and sort of talk what that looks like. So the first key to success they came up with was to ensure all young people with special healthcare needs have an identified healthcare professional who attends to the unique challenges of transition, assumes responsibility for current healthcare coordination, and future healthcare planning. So that says a lot in one long sentence that's hard to read and figure out what it's actually saying. But what I think it's trying to take away is that each person should be passed on to somebody within each world, primary care and each subspecialty, that has an understanding of what that's going to look like, that's willing to continue to provide care, that's going to be able to help coordinate care, which is the key, and then deal with things as they come up in the future, and has some experience and some knowledge. And I think that's the hardest system to find, is pediatric locations and hospitals are very used to all the subspecialties. And then you take and you branch out. So in Pittsburgh, for example, there's Children's Hospital. Anybody with any special health care specific subspecialty needs is centered in one home. And then you go to transition, and now you have practices in the adult world everywhere. They're hard to find to make the connection. And so when you have a program set up like they do in Philly, it's a nice roadmap, I think, for the typical patient going through it. You can ask your provider in each subspecialty, who would you recommend? And you may get someone who has set it up, and hopefully that's the case. You may get some suggestions of names, but I think we need to do a better job of actually identifying the adult providers. My interest is there, as he was talking about the interest that they have there and why it succeeds, to go to Children's, introduce myself, make sure I have a connection, so that when it's time, even though it's not as formal a process, there's a name of somebody for all the transitioning patients and families to be given, who will know where they're coming from, know who their doctor was, have access to the records, and be able to hopefully transition in a more positive way. From the second key to success was to identify knowledge and skills that are required to provide development appropriate health care, and that it may require some extra training, and I agree with that. We recently transitioned a patient who is 29 but weighs only about 30 pounds, and it was part of the trouble that Dr. Meyer was describing. A hospital gown doesn't fit from the adult world. We have to get it from Children's. And so depending, and all the things are different. The behaviors are still more pediatric than adult, and if you have providers who aren't used to that, it makes an impact on the family, the patient, it adds stress and so forth. And so I think on the adult side, it's really our job to try to train more people and expose them to what we have gotten good at, which is advancing care and transitioning more patients with chronic health needs. The third important key, and I think the families can play a role in this, is to prepare an up-to-date medical summary. So for the families that come to me that have a paper that or a notebook or whatever they've collected during their lifetime of who their providers are, what surgeries have happened, what the health problems are. If you use a machine, you know who the company is that provides it, when you use it, etc. It's much more helpful and easier for me to take that patient and transition them smoothly than somebody who comes in the door and doesn't know all of that, just knows, oh, my doctors took care of it. So my one piece of advice to families as you're working that direction is to think about, is there a way you can collect nowadays with all the health records out there in apps and printouts that you get to compile it into a way that it puts it on you and not the physician, but it guarantees the information gets transferred, the key pieces of information that may otherwise get lost if there isn't a set connection between two providers or different health record systems and so forth. I think developing transition plans with families helps when the pediatric side starts it and they involve the patient, the young adolescent, if they're able to communicate and participate. When they come to see me and to meet me, they have an understanding of why they're there, and it's a process that's happened. It doesn't make it less scary, but they're more sort of, the mindset seems to be a little bit ready to handle it and come with an open mind than if it's a, oh, by the way, next time go see an adult doctor kind of process, which I think still happens with some people. I think ensuring the same standards for primary and preventative health care are applied to adolescents and then to adults, and that's one of the big things that is sort of a knowledge and awareness with physicians. So how things are done in the pediatric time in terms of immunizations, testing, routine healthcare stuff. You enter the adult world, somebody with special healthcare needs should still be held to the same basics, and that's one of the reasons for transitioning. I don't think a pediatrician knows when someone needs a mammogram or a colonoscopy. You know, some of our routine adult testing gets lost. You don't learn that as a pediatrician. And so that has to all be maintained. And then making sure, and Dr. Meyer touched on this a little bit, that there is available care and health insurance that can be continued so that you don't lose things that you had coverage-wise, you don't lose equipment, and make sure, especially for people who have home nursing care, et cetera, that that can be maintained and isn't lost, because it's often lost in the process. When I think specifically to pulmonary care, what I think of is in children's, oftentimes, at least in all the systems I've been in, there's a central hub of a hospital, whether it's Children's here, CHOP, or I did residency in Indianapolis, Children's Hospital there, but the pediatric providers tend to go hour, 2 hours to these satellite clinics. And so for people who aren't in a big city, they have access to specialized providers more locally, maybe once a month that they come to the clinic, but they're there, it saves the travel. I think the adult system hasn't done that yet. The adult providers, specific, whether it's a cancer transition, a transplant transition, pulmonary, tend to be in the main hub and not necessarily. So it puts more onus on the patient and the family to now come to the doctor instead of the doctor going to the community. And the adult model hasn't matched the pediatric model in that case yet. Coordination of care is challenging. An example I would have heard as a pediatric resident or tell a pediatrician is we need to get for someone, let's say, with a tracheostomy tube, the trach evaluated, the teeth cleaned, and the ears cleaned out. That's like no big deal in the pediatric world. It just happens, boom, 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 all in one day. To accomplish that in the adult world is like moving heaven and earth. You just cannot get anyone to line up. So it puts more on the patient that they have to do things at different times, adds to the needs and the challenges. And that's the adult system. I don't want to paint it as a negative. I just want to expose the differences. And my hope is that as we create transition programs, there'll be more attention to that, and it will improve. I think it has in places that have pretty well-established transition programs. I think the frequency of testing also varies. So we were talking about this, things like pulmonary function tests, carbon dioxide levels on the pediatric side may be measured every single clinic visit, 3 months, 6 months, whatever it may be. Once you hit a certain level of dysfunction on your pulmonary function test, from being restricted, from being twisted, muscle weakness, the repetition of the test doesn't add anything to the clinical care. I want to take care of you as a patient based on symptoms and other data, and I think that's a big change I see a lot in patients who come to see me. Well, how come I don't have to do PFTs? I always do PFTs. And we talk it through. I'm like, do you want to still do it? I can order it. And once people know, they're like, oh, no, I'm happy not to. But it's getting used to a different system, a different expectation. Sleep studies are the same thing. We often see, especially in the Duchenne muscular dystrophy world specific, every 6 months, every year, they're getting a sleep study. And I may never order a sleep study because we're using other testing, other objective measures. So there's going to be differences. As we age, the body is not necessarily growing this way, maybe getting weaker or twisting, but as the things stabilize, we don't have to do so much of the same kind of testing, or processes are different. I also notice a difference in insurance coverage coming from patients that may be under their parents' health insurance versus merging onto whether it's a Medicaid plan, a self-employer plan, Medicare if they're under disability. And that can really throw a wrench in it if you don't have the knowledge and the questions to ask ahead of time to make sure that what you're transitioning to from an insurance standpoint is going to keep covering the same things. The biggest thing in pulmonary care, I think, is continuous pulse oximetry. For a lot of patients, chronic lung disease, or maybe weak and on a ventilator, they're used to having this pulse ox all the time or while they're sleeping. And the insurance at the adult level doesn't want to cover that. So that takes a lot of fight. Sometimes we win, sometimes we lose. I think management of equipment differs a little bit in terms of who's on top of it, how the durable medical equipment companies see the patients from a pediatric experience versus an adult experience. Makes a difference. Frequency of procedures. Someone with a trach in the peds world, they get a scope looking down that trach very regularly as the airway is growing, making sure the size is right. Once you hit the adult size, we don't need to change that or do much in that way. So that changes things. So there really is little nuances, and my hope is that with people who are interested, there can be a connection between your pediatric homes and someone on the adult side that makes this easier. For those of us who do it and like it, it certainly works. And it's just really within each area of the country or the world, from people who are here from other places, trying to figure that out, and interviewing the provider is my best recommendation. You don't have to tell them you're interviewing them, but go to the first visit with open eyes and ears, but lots of questions to figure out, do they really understand what I have been through, what my disease is, what my needs are. If you mention cough assist and their eyes go, huh? Then probably that might not be the best person if you need cough assist. So that's just one example, but I think that's the stage of life, is figuring out who you can connect with and remembering the 18 years of relationship, if it's from birth to 18, maybe it's 5 years if it's starting in teenage time. It takes time to build. So on the flip side, you're not going to feel the same way about the adult provider on day one. You may have a good feeling and a liking, but you don't trust them and have the relationship yet. That takes time to build. And so I think that's the key of transitioning people when they're at a stable place and not an up and down place, is so you can get to know someone. The first thing I tell all my patients when they come is, I'm here to get to know you today. My plan is not to change anything unless you have issues that you want changed. So that it's sort of an expectation that I'm not the new person in town trying to reinvent the wheel and make things different. So that's sort of my summary from the adult side, and happy for us both to take questions or answer anything we can.
So it seems like CHOP has a good transition model set up. Are you aware of other hospitals or associations that help that model if one is not existing currently?
I guess the answer I would give is not yet. We actually put on a symposium back in January, and Mike was able to join and present the RYR1 perspective. And one of the things we're trying to do is to put together standards and sort of a model. I'll freely admit that we were very, very fortunate in that our adult program started in part because they got funding. And that's not an expectation that's reasonable at every institution. We're very, very fortunate with that. But what that did give is an opportunity to try a model or try models and find ones that worked. The only reason the program is really working the way that it is because Dr. Hansenflash and he started the program, was able to recruit 3 and soon to be 4 junior faculty members to see this as an interest. I'm sure, struggle with finding a pediatric neurologist, a pediatric pulmonologist, a pediatric orthopedic surgeon, and at least having the talent there is an important part. I've talked to other colleagues, I know in Cincinnati, and then I think at one of the hospitals in, I think, UT Southwestern, where their program started because of the really the strength and the passion of the adult neurologist that really went and said, look, we have all of these Duchenne patients, all of these SMA patients who need to come. You need to help support putting a center together. So your question is a very good one, because in time I hope that we'll be able to provide models and then the ability to support colleagues elsewhere trying to put programs together.
That's a two-part question.
Okay.
That part. Second part, the expectation, it sounds like, and I don't know this because I haven't experienced it firsthand, but the providers are very fragmented. It's not multidisciplinary. Is that the case? Where there is no model, you have to see a neurologist and a pulmonologist and a nutritionist, et cetera, on your own, or does that kind of exist in other places as well?
I'll talk about our experience, and then Jen can talk about hers. Our adult program is, call it fractured or not multidisciplinary. And I think my understanding from my adult caregivers, my adult colleagues, is that that's because there's not really a model for being able to do multidisciplinary care in chronic disease. That's at least how it is at Penn, and I don't know what it's like at.
Yeah, I think the difference a little bit is in the payment structure model and the way that pediatrics looks at reimburse. Like, I'm not trying to make it money, but healthcare is money, and this is not I don't think this is correct, but I think the reality is the way pediatric reimbursement and everything works, they can make it work, whereas on the adult side, the way that reimbursement structure is, it doesn't work to date in the current U.S. healthcare system, and that's the limitations and the challenges of it. I also think pediatrics worlds tend to be more centered in one place, whereas if I look at UPMC here, we have cardiology subspecialty in one building, urology's in another building. Like, you just have people in totally different areas because they're bigger and broader. There's more adult patients seeing those subspecialties because there's more people from 18 to 100 in the world, and children's naturally is sitting in one house. But I think my wish and reality is that it would work better, and I think with every model that has come about, you can see it works in other programs. It's just a matter of having more interest. So right now, I can think of a lot of the pulmonary neuromuscular niche, at least, speaking from a pulmonary standpoint, not other subspecialties, exists at most of the major academic medical type centers. It may not be established, a lot of the way theirs is, which is funding, probably more related on the administrative side of things, but on the physician side of things, it exists just on a less advertised, smaller scale, which is what happens here in Pittsburgh with me and children's. And I have 2 colleagues with me, and so we sort of transition into our clinic from the pediatric side, but it's not labeled, it's not a set program, it's not handled the same way. It's the goal to get there, working on it every year, but I think that exists places, it's just not as established.
Can I just ask a follow-up related to that question, please? So if a child is covered through Medicaid for disability or income, depending on the state, and then reach that threshold of whatever it is in that state, 18 or 21, does that usually fall away at that point?
Well, there's a different coverage scheme. There's Medicaid and Medicare, and there, at least what we found is that the contracts that each provider had are different. We were part of the Medicaid, New Jersey Medicaid, because there was no comparable pediatric facility across the Delaware River in New Jersey. That wasn't the case for Penn. And so, that's why we had to, get an exception and get a prior authorization.
Yeah, and I think every state is different too,
Yeah.
and in that aspect, every Medicaid program is from that aspect is different.
I have a question. You mentioned like having a one-pager in terms of kind of a history to make it accessible or digestible, but when you have a child that has a complex history, I can write you 160 pages
Yeah.
and you might get through age 8. So how do you recommend distilling that into something that's usable without going into too much detail? Is it sort of like high level with like big hospitalizations over the lifetime and surgeries, or like it feels like a lot of information to try to distill down, and I even think about this not just giving it to a physician, but even continuity of care. If something happens to us, like how do we have something that's digestible for somebody else to take over? And any insight you could provide would be helpful for, like I said, personal and just thinking about future.
Yeah. So one pager, probably for some, is not one pager. It's longer for sure. The one pager that is helpful, I think, is sort of the who, especially for someone who can't advocate for themselves, can't communicate, is the who am I page that may have big, huge things of like, I have this heart problem or this lung problem, but may also say, I like to be called this. Like, I eat only this food. Like things that will make a huge difference when you walk into the emergency room somewhere, for example. From a physician transitioning standpoint, I think it needs to be a few more pages if they exist. And if you're transitioning to someone who wants to understand and take over the care, they want that information to be able to digest it and really to get to know who the patient is. Do you need to have every bump, scratch? Probably not, but I think you're right. The big things, surgeries, major hospitalizations, things that really contribute to the everyday being of the person. Does that answer?
One other
But
question.
8 pages is fine if it's 8 pages.
I'm so sorry to interrupt. We
Yeah.
have like another
Yeah.
No problem.